my talk on difficult laparoscopic cholecystectomy, comparative predictive values on various radiological indicators, which is done under the guidance of Dr. Krishnakant Singh, Professor, King George Medical University, Department of General Surgery, Lucknow, India. Laparoscopic cholecystectomy. Laparoscopic cholecystectomy, the acceptability of laparoscopy as a gold standard is attributed due to small incision, less intraoperative blood loss, reduced post-op pain, early recovery, and better cosmetic result. The first
Shubham,
laparoscopic yes,
Shubham,
sir. Yes, sir.
give some more time into the between your words. ठीक है ना,
Okay, sir.
शब्दों के बीच में give some more some time. You are getting
O-
really fast, right?
Okay, sir.
Hmm.
The first laparoscopic cholecystectomy was performed by Moret in Lyon in year 1987 and 88. Reddick was the first to popularize the laparoscopic cholecystectomy in the year 1990. So nowadays, more than 50 different techniques are done for laparoscopic cholecystectomy. Coming to my topic, difficult laparoscopic cholecystectomy. What is difficult laparoscopic cholecystectomy, sir? Sir, on the basis of prolongation of surgical time, intraoperative injuries, and the presence of anatomical structure and intraoperative pathologies such as adhesions, impacted stone, contracted or distended gallbladder, or difficulty in assessing the Callot's triangle due to severe inflammation and a host of other conditions, sir. On a very end note, on a key end note point, difficult laparoscopic cholecystectomy is conversion to open surgery or duration of surgery being prolonged for more than 60 to 70 minutes. Moreover, a high biliary injury rate could also be related with difficult laparoscopic cholecystectomy procedures. Now, grades of laparoscopic cholecystectomy. Sir, laparoscopic cholecystectomy is divided into 4 grades. The first one is grade 1, which are easy and uncomplicated cholecystectomies. Grade 2 is associated with medium difficulty with mild cholecystitis. Cystic duct or artery is obscured by adhesions or by fatty tissue, and gallbladder presented with mucocele or pyocele. Whereas grade 3 laparoscopic cholecystectomy are those difficult cholecystectomies which are due to either gangrenous cholecystitis, shrunken fibrotic gallbladder, due to severe cholecystitis, formation of subhepatic abscess, and Hartmann pouch adherent to common hepatic duct. Cases in which the cystic duct or artery are difficult or impossible to dissect, or there is liver cirrhosis associated with portal hypertension, are graded as grade 3 laparoscopic cholecystectomy. Whereas grade 4 is as simple as to conversion of procedure into open, which is required and necessary. So also in year 1995, Nasser and al. Classified the difficult laparoscopic cholecystectomy again into 4 grades, which are as follows. For the grade 1, the gallbladder is floppy and non-adherent with thin cystic pedicle, and with the cystic pedicle is very clear. Adhesions are just simple and they are up to the neck or associated up to the Hartmann's pouch. Whereas in the grade 2, the gallbladder is associated with mucocele or pyocele, or gallbladder is just packed with stones, with cystic pedicle is laden with fats. Adhesions are simple up to the body of gallbladder. In grade 3 of difficult laparoscopic cholecystectomy, the gallbladder is associated into deep fossa. The gallbladder fossa is very deep, or intrahepatic gallbladder, which we can say, associated with acute cholecystitis, whereas contracted or fibrous gallbladder with Hartmann's adherent to common bile duct, whereas there is impactation of stone at the GB neck or gallbladder neck, with cystic pedicle being having an abnormal anatomy, or where the cystic duct is very short and dilated or obscured, which are very difficult to clip upon. And adhesions are very dense, involving fundus, hepatic flexure, duodenum, or transverse colon as well. Whereas in the grade 4 of classification of difficult laparoscopic cholecystectomy, the gallbladder is completely obscured, may be associated with empyema or gangrenous changes, associated with mass, with cystic pedicle is impossible to clarify, with adhesions are as such dense, which are with wrapping the gallbladder all around, involving other adjacent structure, which are duodenum, hepatic flexure, stomach, and transverse colon or omentum. Now we are coming to the preoperative predictors of difficult laparoscopic cholecystectomy. For more than 3 decades, surgeons throughout the world have been directing their researches on identification of risk factor associated with difficult laparoscopic procedure and their quantification as well. The possible factors that could lead to difficult laparoscopic cholecystectomy procedure are divided into 3 parts, which are clinical, with patient history related factors, physical status of patient, clinical or laboratory findings, and intraoperative factors also. Now coming to imaging modalities, which are showing the so in the difficult laparoscopic cholecystectomy that are abnormal gallbladder like thick gallbladder wall, gallbladder shape is small or contracted, or maybe distended gallbladder due to stone impactation, gangrenous changes, perforated gallbladder, or associated with syndromes like Meiji syndrome, or patient with cirrhosis and portal hypertension has also shown to be associated with difficult laparoscopic cholecystectomy too. Presence of an impacted stone in Hartmann pouch is very important for pointing out the difficult laparoscopic cholecystectomy because it leads to inflammatory changes that lead to thickening of gallbladder neck and cystic duct, resulting to the long-term fibrosis. And also, a short and wide cystic duct may not be very much amendable for safe clipping, and that can be challenging in intraop as well. Also, a large liver and big gallbladder could also result in difficulty as they have shown to interfere with the operating field, hampering the adequate exposure of the surgeon and thus slowing down the operative procedure and including the procedure to conversion as well. Anatomical variations such as those caused by Meiji syndrome, cholangiocarcinoma, or choledochal cyst may also disturb the normal anatomy of Collard's triangle, which might result into difficult laparoscopic cholecystectomy and wherever required may convert the procedure into open too. Now coming to the aims and objective of our study. The primary aim of our study was to identify the preoperative radiological predictors of difficult laparoscopic cholecystectomy and compare their predictive values as well. The objective was to find out the accuracy of different pre-surgical radiological predictors of difficult laparoscopic cholecystectomy. The various radiological predictors which were taken into the account of our study was multiple large stone, dilated gallbladder, contracted gallbladder, presence of peripancreatic fluid, and thick gallbladder wall. Now coming to the material and methods. Our study was a prospective observational study which was done in the Department of General Surgery, King George Medical University, Lucknow. Study population was taken as cases which were planned to undergo elective laparoscopic cholecystectomy, and sample size was calculated depending upon the previous studies. The average prevalence rate of the difficult laparoscopic cholecystectomy was around 2 to 6%, and the calculated sample size was 59 for our study. Now coming to methods. At the time of enrollment or at preoperative stage, the following data were obtained from the patient. That were some initial age, sex, height and weight of the patient, body mass index, any prior medical or prior surgical history which was very important, presenting complaint of the patient, laboratory evaluation, ultrasound findings, and quality of life assessment. Now inclusion criteria for our study. Inclusion criteria of our study was all patients of different age group with symptomatic cholelithiasis without any absolute contraindication for general anesthesia were included in our study. All patients should have ultrasonographically proven cholelithiasis were included in our study. No other any radiological tools were taken into the account. Exclusion criteria: patients who were unable to tolerate general anesthesia were excluded. Patient having any significant comorbid illness was also excluded from this study, and patients who were not willing to participate in the study were also not taken into account. Now coming to intraoperative observation of our study. In the intraoperative observation, the length of operation was seen and conversion to an open procedure if any was also taken into the account. The operative time was calculated from the initiation of skin incision to the complete of skin closure. The skin to skin time was calculated. The hospital stay was calculated from the day of surgery until the discharge, and adhesions to the gallbladder region was graded subjectively depending upon the surgeon, as it was classified as absent, mild, moderate, and severe depending subjective upon the surgeon's assessment. The laparoscopic cholecystectomy was performed as per the standard 4-port technique. Now determination of difficulty. Patients were divided into three groups. First group was of not difficult, second was associated with difficult, and third group was of extreme difficult laparoscopic cholecystectomy. The non-difficult group patients were having a smooth surgery with time duration of less than 60 minutes. In difficult group, significant ascensions and contracted gallbladder was seen. There were aberrant and congenital anomalies. There was also a difficulty in creating pneumoperitoneum initially, and there was also a difficulty in holding over the distended gallbladder. In the case of the extremely difficult group, there were injury to the adjacent organ, injury to blood vessel, and slipping of cystic duct as well. Now coming to the observation and findings of our study, we have taken into account of 59 cases. Out of 59 cases, 34 cases had no radiological predictors for difficult laparoscopic cholecystectomy, and no intraoperative difficulty were found, and the procedure went smoothly as well. But in the rest 25 cases, we had positive radiological predictors of difficult laparoscopic cholecystectomy. This comes into the account. Now, seeing the observational chart of our study, the radiological predictors of difficulty were noted as follow. 5 radiological parameters were taken into account, which were multiple large stone, dilated gallbladder, contracted gallbladder, presence of peripancreatic fluid, and thickness of gallbladder wall. For multiple large stone, total number of 4 patients were having the multiple large stone upon ultrasonographically finding, out of which 1 patient turned to be difficult, 3 went smoothly. Same goes with the dilated gallbladder, where total two number of patients were having the dilated gallbladder upon sonographically finding. 1 went with difficulty and 1 went smoothly. Contracted gallbladder, total 6 patients were having contracted gallbladder upon ultrasonographic finding. Three of them were difficult, of them were easy procedures. But here we see that peripancreatic fluid, total presence of peripancreatic fluid preoperatively upon ultrasonographically finding was upon 9 patients, out of which 6 patients went under difficult laparoscopic cholecystectomy and 3 went smoothly, with statistical significance of less than 0.01. Now coming to thick gallbladder wall, total number of 4 patients were taken into the account with thick gallbladder wall preoperatively upon ultrasonographically finding. 2 of them were categorized into difficult, 2 went smooth. Coming to the result of our study, among the radiological features, presence of contracted gallbladder, presence of peripancreatic fluid, and thick gallbladder wall were found to be significantly associated with difficulty, with mean duration of procedure was significantly longer in difficult procedures as compared to the easy procedures. Conclusion and significance. Now, from this, we concluded that peripancreatic fluid is the most significant preoperative radiological predictors of difficult laparoscopic cholecystectomy with the p-value or significance value of less than 0.001 in our study. Although less but contracted gallbladder wall and contracted gallbladder and thick gallbladder wall also have statistical significance in the study. This gives important advantage to us or a surgeon who has to perform the surgery to organize the operating room for necessary resources and also priorly counsel the patient for conversion if necessary or required in the intra procedure. Whereas to conclude with the difficult laparoscopic cholecystectomy as per our study was the cholecystectomy with the duration or operative time of more than 60 minutes or with dense fibrotic adhesions near Calot's triangle and or impacted large stone at bladder neck associated with Meiji syndrome or having a history of the biliary pancreatitis with common bile duct stone or cholelithiasis or with acute cholecystitis of duration of more than 72 hours at the time of presentations were taken into the account. Now, preoperative predictors of difficult laparoscopic cholecystectomy need to be further explored because 2 to 15% of patients undergoing laparoscopic cholecystectomy may result into conversion of the procedure too. With this, I conclude my talk on the various radiological predictors of difficult laparoscopic cholecystectomy. Thank you for your patience. Have a nice day. Thank you.